Okay, chapter 26, excuse me. Lecture burst for caring for a client with cardiac arrhythmias. Um, Learning objectives: name and describe common cardiac arrhythmias, identify medication to control or eliminate arrhythmias, explain the purpose of and advantages of electrocardioversion, explain when defibrillation is used to treat arrhythmias. Describe the nursing management of a client with an arrhythmia treated by drug therapy, cardioversion, defibrillation, or pacemaker insertion. And discuss the purpose of implanting an automatic internal cardiac defibrillator. Normal sinus rhythm, heart rate is between 60 and 100 beats a minute. It comes from the SA node, which is the pacemaker to the heart. Initiates the impulse. The impulse travels down to the AV node in about 0.12 to 0.2 seconds. Ventricular depolarization in 1.12 seconds or less. Impulse occurs regularly. Atrial arrhythmias originate in the sinus node, sinus bradycardia, sinus tachycardia. And then atrial arrhythmias developing in the sites outside the SA node, premature atrial contraction, supraventricular tachycardia, atrial flutter, and atrial fibrillation. Cardiac arrhythmia is atrial, sinus bradycardia. Bradycardia is there are arrhythmias that proceed normally through the conduction pathways, but at a slower than usual rate, so less than 60 beats a minute. So if you're looking at those 60 beats a minute, if it's 60 beats a minute or above, it's sinus rhythm. If it's less than 60 beats a minute, it's sinus brady, as long as you have a P, a Q, a R, S, and a T with each heartbeat, okay? Causes: identify healthy athletes. I've taken care of people that have waken up after surgery and their pulse is 45. But this is also a guy that runs triathlete. He's a triathlete. He runs 50, 60 miles a day. I mean, they're crazy. Heart disorders: increased intracranial pressure, ICP, hypothyroidism, digitalis toxicity. Danger is that the slow rate may be insufficient to maintain cardiac output. So that's the biggest part, that you have to be careful with that. Medical management: atropine sulfate, a cholinergic blocking agent that is given IV to increase a dangerously slow heart rate. And when you're talking dangerously slow heart rate, you're talking a person that is symptomatic. They're nauseated, they're vomiting, they're having all kinds of sweaty perspirations. They don't feel well, and you have to put them in Trendelenburg. Okay, this is what the sinus bradycardia looks like. You notice that there's a P, a Q, R, S, and a T wave with every single one, but there is, 1, 2, 3, 4, 5, 6 big boxes between those. So that's on the EKG paper. So you have to look at those, okay? We'll discuss those more later. Cardiac arrhythmia number 2, sinus tachycardia. Arrhythmia that proceeds normally through the conduction pathways, but at a faster rate than normal, greater than 100 beats a minute. 100 to 150 is the usual rate for these arrhythmias. Causes: a physiological response to strenuous exercise, anxiety, fear, pain, fever, hyperthyroidism, hemorrhage, shock, or hypoxemia. Okay. Premature atrial contractions, PACs. This is something that happens in a few people. It is a premature atrial contraction that comes along, and the neural tissue in the atrial conduction system initiates an early electrical impulse, which is identified by an irregularity in the underlying rhythm, causes caffeine, nicotine, or other sympathetic nervous system stimulus, heart disease, metabolic disorders, or hyperthyroidism. Automaticity of the atria or a re-entry mechanism may warn of an initiate supraventricular tachycardia. Treatments depends on symptoms. Beta adrenergic blockers, beta blockers, may be used to decrease the PACs. Okay, and then this is what a PAC looks like. Okay, or this is a sinus tachycardia. Excuse me. This is what a PAC looks like. Different configuration of the P. You see the P down here on the first one. It's upright, it's normal, but then you go along and you have that one that's going down, not going up. And then if you look at the QRS of this one, the QRS is the same because it's still coming from the right direction, but there's an incomplete compensatory pause. Okay, so that's a little bit of a spread out there because the atria has to repolarize to get you going again. Okay, so you look at a normal sinus rhythm, you have your P, QRS, and T. Sinus Brady, you have your P, QRS, and T, and sinus tach, you have your same. It all comes through there in the same format. Okay. Supraventricular tachycardia, SVT, arrhythmia in which the heart rate has a consistent rhythm but beats at a dangerously high rate, greater than or equal to 150 beats a minute. Diastole is shortened, and the heart does not have sufficient time to fill. So your cardiac output drops dangerously low, and you wind up not having enough output to keep things going if you're standing up. Assessment findings: chest pain, tachycardia, angina, another word for chest pain, hypotension, syncope, reduced renal output. Medical management: digitalis, adrenergic blockers, calcium channel blockers. Adenosine is used for SVT sometimes to make sure that that's what it is. Okay. Atrial flutter. Now, atrial flutter, one thing that it is noticed, you can notice atrial flutter just looking at a QRS on the paper because it has sawtooth waveforms. Okay, the atrial wave is a flutter wave, and it is usually even. There's usually 3 or 4 or 2 in between each QRS. The QRSs are equal, and it is a marching out, and it's ranged from the SA node causes the atria to contract at a exceedingly rapid rate, 200 to 400 contractions a minute. So the top of your heart is just beating away and not giving much pumping action to your ventricles. So you lose about 30% of your what they call your atrial kick, so that you don't have the atria helping you along there, okay, for your cardiac output. So atrial fibrillation, atria quivers rather than contracts. Ventricles respond at the atrial to the atrial stimulus randomly, causing an irregularly ventricle heart rate. Okay, so it is what they call irregularly irregular. May be too infrequent to maintain adequate cardiac output. Complications: formation of blood clots within the atria, stroke causing emboli if it enters the circulation. I am a atrial fibrillation patient. I am on beta blockers, calcium channel blockers, ACE inhibitor. I used to be on ACE, but now I'm on ARB. Risk is higher with structural heart disease, hypertension, and an age of over 65. I'm not over 65, okay? Treatment goals are decreased in ventricular response and conversion to a sinus rhythm. Drug for rate control include digoxin, which I'm not on, beta blockers, which I am on, calcium channel blockers I'm on, and anti-arrhythmia drugs used for conversion. Then you could have somebody that gets direct current cardioversion, so that's that electrocardioversion. May be used to convert atrial fibrillation to a normal sinus rhythm. Anticoagulant therapy, that's what I was on up until December. I was on Eliquis, and they changed me off of Eliquis. No, they put me on Eliquis, and I had a bleed in my brain. So I had a subdural hematoma. And so I'm fine now. I've been checked off. I'm good to go. But they don't use Coumadin as much as they used to, especially not for atrial fibrillation. So that's where you're at now. You use some of the newer drugs that have come out. Okay. A client presents to the emergency department with complaints of syncope and chest pain. The EKG results indicate that the client has supraventricular tachycardia. The nurse anticipates the treatment of this arrhythmia is A, B, C, or D. Okay? And it is D, digitalis. Digitalis adrenergic blockers and calcium channel blockers are used to slow the heart rate. Okay? So that's what you're looking at. So cardiac arrhythmias, atrioventricular is the next one. And that's what they call heart block. Okay? Disorder in the conduction pathways that interferes with the transmission of impulses from the SA node through the AV node and down into the Purkinje fibers and the rest of the heart. The types of first degree, second degree, and third degree complete heart block. People walk around with first and second degree heart blocks all the time. The impulse is delayed. That's where that P and QRS, that's greater than 0.20 seconds for the impulse to get through. Complete heart block, the atrial impulses never gets through, and the ventricles develop their own rhythm. It's called automaticity, independent of the atrial rhythm. Ventricular rate is slower. 60 to 100 for the SA node. The ventricle rates are 30 to 40 beats per minute. Treatment for a complete heart block is a pacemaker insertion. Types of yeah, that's right. Sorry about that. Types of premature ventricular contractions, ventricular tachycardia, and ventricular fibrillation. Premature ventricular contractions of PVC, people have those all the time, and most of the time they don't even know they're having them. Unless, of course, they have couplets or runs or something like that. And then they get lightheaded and dizzy, and then they fall down and go boom. Ventricular contractions that occur early and independently in the cardiac cycle. Before the SA node initiates the electrical impulse, no P wave precedes the wide, bizarre-looking QRS complex. Assessment findings: pallor, nervousness, sweating, faintness. they faint. Fluttering in their chest, sensation, and I get that with my atrial fibrillation. I get that flutter feeling. Medical management: occasional PVCs may be harmless and may be related to anxiety, stress, fatigue, alcohol withdrawal, or tobacco use. Now, precursors to lethal arrhythmias, 6 or more PVCs per minute. Okay, if you're having more than 6 beats of PVCs in a minute's time, there's something wrong. Runs of bigeminy, that's where every other beat of your heart is a PVC. So you've lost a lot of output that way, because every other beat has nothing to pump into your blood because it's premature and it's not filled. 2 PVCs in a row is called a couplet. Runs of PVCs 3 or more in a row. Multifocal PVCs originate from more than one location in your ventricle. So one might come from the front, mine might come from the back, or the top, or the bottom, or whatever. And they look differently. You're going to see one here in just a minute. A PVC whose R wave falls on the T wave of the preceding complex R on T phenomenon, and usually goes into VTAC or something like that, more dangerous than you see. All right, ventricular tachycardia. Single irritable focus in the ventricles that initiates and then continues the same repetitive pattern. Ventricular beats of 150 to 250 beats a minute. What do you think happens to your cardiac output? It goes down to the toilet. It decreases. Most people cannot tolerate 150 to 200 beats a minute. They will pass out on you almost immediately. If not pass out, they have a syncopal episode. They fall down. They they're sweaty. They're cold and clammy. Client may lose consciousness. Ventricular tachycardia sometimes ends abruptly without intervention, but often requires defibrillation and may progress to ventricular fibrillation. Use unsynchronized cardioversion may be needed. Ventricular tachycardia without a pulse is treated like ventricular fibrillation, and rapid defibrillation is attempted. Okay? This is VTAC. Okay? And as you can see, it is rapid, it is fast, it's right there in between. So the big boxes are, the first one, if you look at that 1, 2, 3, 4, 5, fifth one over, that one's right on the big box line. So the next box over is 300 beats a minute. The next box over is 150 beats a minute. So this one here is a little bit less than 150 beats a minute. Okay. So cardiac arrhythmias, ventricular fibrillation. Now, ventricular fibrillation is a rhythm of a dying heart that is getting multiple ventricular and no atrial contractions, hardly at all. PVCs or ventricular tachycardia can precipitate it. Ventricles do not contract effectively, no cardiac output. It's basically your ventricles are just sitting there quivering like a bowl of jelly because they have multiple signals coming in at the same time. Okay, so this is a picture of ventricular fibrillation. It's erratic. It's, there's nothing there. There's no P, there's no Q, there's no RS or T. It's just there. Okay. With this one here, you start CPR and you defibrillate them as fast as humanly possible. Okay. Question number 2. A client is experiencing premature ventricular contractions and reports a fluttering sensation in their chest. The nurse explains the cause of this client's symptoms as, which would you say? The ventricular contractions occur early and independently. A premature ventricular contraction, or PVC, is a ventricular contraction that occurs early and independently of the cardiac cycle. So that's all you tell them. And if as long as that's all they have, they're fine. So another type of fatal arrhythmia is pulseless electrical activity, PEA. Electrical activity can be observed on an EKG, okay, but there is no mechanical activity of the ventricles and the patient has no pulse. So clinically, what you're going to do is you're going to take and correct one of the common causes of PEA: hypovolemia, drug overdose, MI, hyper or hypokalemia, pulmonary embolus. Those are the things that cause pulseless electrical activity, and so that's what you're going to do. Yeah, they have you. Okay. Diagnostic findings for all cardiac arrhythmias. Monitor rhythm strips or 12-lead EKG identify the arrhythmia. Electrophysiology studies produces actual arrhythmias by stimulating structures in the conduction pathways. Determines the best method for preventing further arrhythmic episodes. Eradicates tissue in the area of the heart that is producing the arrhythmias. Now, my wife is a cardiac nurse and she is trained in electrophysiology, and she actually helps Dr. Rome, and that from Pulse Heart Institute. She is his nurse, and she's been at that for almost 20 years now. So she's been doing it quite a bit. This is what a normal 12-lead EKG looks like. Okay, so that's what you're going to look at. Medical and surgical management of arrhythmias. Drug therapy, oral and IV antiarrhythmic drugs are used to treat clients with arrhythmias. If they're coming into the hospital, they're more than likely going to get them IV until they get that arrhythmia under control, and then after that they switch them over to an oral antiarrhythmic drug. Elective electrical cardioversion, try to say that fast, is a non-emergent procedure to stop rapid but not necessarily life-threatening atrial arrhythmias, depolarization, the entire myocardium. So it goes up there and it really shocks them. Give them beryllium these days, and it makes them sort of pass out. And we shock them, they don't hurt, they don't even remember it, which is a lot nicer than the old way that we used to do it. We used to give them Versed or Valium, and they would remember it, and they would cuss and swear and jump up and down and everything. So it wasn't very fun. Defibrillation, only treatment for life-threatening ventricular arrhythmias. Uses pulseless ventricular tachycardia, ventricular fibrillation, and asystole cardiac arrest when no identifiable R wave is present. Okay? Now the Q is the downward stroke, the R is the first upward stroke, and the S is the downward stroke after the R. Types: automatic external defibrillator, AED, and that we use those in the hospital. You might see them in a nursing home, but usually not. In nursing homes, you have to just do CPR until the paramedics get there. Automatic internal implanted cardioverted defibrillators, AICDs. They just call them ICDs now, implanted cardiac defibrillators. Internal electrical device used to select clients, just about anybody that has a possibility of a life-threatening tachyarrhythmia, they're going to get one, unless they're too old for it to qualify for their insurance. But 99% of the time, somebody has a cardiac arrest and they're going to have another one, they put a defibrillator in them, and that. So anyway, medical and surgical management, again, pacemakers, provides an electrical stimulus to the heart muscle to treat a ineffective bradycardia arrhythmia. Demand is synchronous mode. Pacemaker self-activated when the client's pulse falls below a certain level. Usually is set at 70-72 beats a minute. Fixed rate asynchronous mode pacemakers usually run between 72 and 80 beats a minute, despite the client's natural rhythm. Permanent or temporary. Most of the ones I see or have seen are permanent. They don't change them out. Then there is a radio frequency catheter ablation. These are some newer things that are heated up there. The heated up catheter tip destroys arrhythmia producing tissue. My wife has had one of these. Actually, she's had two of these in her atria. And complications are bleeding, perforation, thrombus, pericardial tamponade, and we'll learn about those in a little bit. Nursing care plan, client with arrhythmias, nursing diagnosis, decreased cardiac output, maintain physical and emotional rest, provide supplemental oxygen, nursing diagnosis, ineffective management of therapeutic regime. Identifies the guidelines for withholding medication, provide information on precautions required with an AICD or pacemaker. So question number 3. Which of the following statements would require additional instruction to the client and their families regarding permanent pacemakers? Okay. Read those. Think what you say. Think about what you're going to say. D. Resume normal activities, including lifting after pacemaker insertion to avoid arm swelling. But they do have a limitation on movement of that arm, the side that it is on, for 6 to 8 weeks until it sets and heals. So you don't want them to go out and start chopping wood the next day after an implanted device. Okay? So that is it. And I will see you when I see you. Be safe. Take care. Okay? Come on.